Hello, everyone. Thanks for joining. My name is Dr. Patrick Connor. This is Dr. Brian Loeffler. We're both part of the Shoulder and Elbow Center at OrthoCarolina, and we're back here today with another installment of OrthoCarolina's live webinar series. This month's topic is on rotator cuff repairs and tendon transfers about the shoulder. We look forward to sharing with you some of the things we've done here at OrthoCarolina. Of note, a replay of this will be posted on OrthoCarolina's Facebook and YouTube channels. And also, if you have any questions over the course of this, feel free to drop them in the comments and we'll address them at the end of our presentations. So thanks for being here. I'll start off with some comments about rotator cuff problems in general, overview, some treatment options, talk about what we do to fix them, and some interesting and exciting ongoing research and development that we've been working on. In general, the rotator cuff is a group of four muscles that join together as a cuff of tissue and attach to the top of the shoulder. And their main function together is to stabilize the humeral head and the socket, so stabilize the shoulder. And the rotator cuff is anatomically predisposed to wear and tear. And so if there's any weakness of the rotator cuff or any injury, what happens is that when we raise up our arms, that ball goes up in the socket. It can pinch on the undersurface of the bone up on top called the acromion, and it can wear the rotator cuff, and it gets a bit worn over time, particularly with overhead activities. And then if somebody has an injury superimposed, whether it's pickleball or out in the garage or just falling up a couple stairs, then that can injure the rotator cuff further, and then all of a sudden there's a rotator cuff tear as shown there at the bottom right. The way this presents is patients come in, they have this deep, boring type shoulder pain, oftentimes in the upper arm, worse with activities. It's hard to get a good night's sleep. And the treatment at first is to try to get it better without surgery. Of course, we do physical therapy, stretching, strengthening, occasionally an injection might help it, the tincture of time, activity modifications, but ultimately, because we know rotator cuff tears don't heal on their own, the ultimate decision becomes, okay, or is it okay to coexist with, or does a patient need to get it fixed, which is with surgery. And what the goal of surgery is to go in the shoulder, whether through an open incision or through a scope, and repair that rotator cuff tear, get rid of that bone spur that's pinching down on it. We don't do this through an open surgery anymore, almost exclusively through a scope, but that's a long surgery. It's difficult to perform, and the rehabilitation protocol, as many of you may have either experienced or have heard of, can be quite long. The typical or standard rehab is 6 or 8 weeks in a sling, and some would say it takes a good 6, 9, sometimes even 12 months to fully recover from the surgery. It's a long, painful process. And unfortunately, there's some issues with lack of healing, frozen shoulders, et cetera, which we'll talk about. A couple comments about the history of rotator cuff repair. When we first started doing this through the scope, we have to attach the tendon to the bone. And the way we would do that is put these little screws in the bone that had sutures coming out of them, which are called suture anchors. We'd pass that through the tendon and then tie them down. At first, we just use a few of these anchors and essentially spot weld, if you will, that rotator cuff on the humerus. We felt good after the surgery, but those didn't heal very well in the early stages. And then later, we would put more anchors in more locations, almost a double row, if you will, to try to get more points of fixation, which improved the results, but it's technically difficult to do, essentially operating through a straw. And so in 2006, there was some new techniques described, which were easier and were essentially the way that many rotator cuff repairs are performed today. And I have that in yellow on the slide here because there hadn't been any substantial improvements in the way we've done it since 2006 until recently. One of the concerns is that it's hard to get that tendon to heal down to bone, and the average percent that does not heal is 20 to 40%. Some patients can still do well clinically with this, but they have a lack of tendon healing 20 to 40% of the time, which is really a high number. And if you compare that to other failure rates of other things that we do in orthopedics, even a low back surgery, a herniated disc surgery, the lack of healing of that rotator cuff is higher than that. And so one of the things that we've looked at was, well, what's the economic costs of these rotator cuffs repairs that fail? We published a few years ago and showed that 1 year's worth of rotator cuff repair failures can cost an economic burden of over $400 million. And so that's every year. And so it doesn't take long to add up and get into the billions of dollars. So certainly there's an economic cost to it as well. Why are these failure rates so high? Well, there's a lot of reasons. The rotator cuff and the shoulder joint are complex. There's blood supply issues, patient-specific issues. Smokers, we know, don't heal as well as non-smokers. A lot of different issues, but one is because it's technologically difficult. It's hard to repair this, particularly when we're doing it through a scope. And so the capability of the surgeon combined with these limitations may be the most important factors associated with success or failure. So there's been an opportunity to redefine the way rotator cuff tears are repaired through a novel system that can achieve stronger repairs. So we started some research at a way to repair rotator cuffs better, stronger, more efficiently in 2020. And this is just a schematic of how it's done. A small little pin is placed through the tendon and through the bone, where this little anchor goes in the bone and is flipped underneath the surface of the bone, and then the suture is tensioned in between each one of these little anchors. So it's almost like a sewing machine rather than a needle and thread. And so it provides a very, very stable repair. We've started using this. Here's just an example of a T-shirt sewn down to the little saw bone there. It shows how stable that is. We've looked at the mechanics of this, and the separation of that repair in the previous technique is in like 2 to 4 millimeters of separation, and with this new technique, it's much less. And we've shown that even the maximum force a rotator cuff can generate, we put that through 500 cycles in the lab, and shown that the tendon doesn't separate hardly at all, and the maximum strength of it is almost double from the previous techniques. And so here are some examples of the kind of the befores and afters, if you will. The tears on the left and the repairs on the right. You can see how that hole is sewn down. It's sewn down to the bone. These are just a few examples I'll go through kind of quickly. Here is an MRI on the top left, which shows the separation, which the tear was. Here's the tear of the rotator cuff on the top right. And then this is an MRI 4 months later that shows that tendon has come down and is repaired down to the bone without any more of that separation. Again, just some more examples here of the of different rotator cuff repairs. Some of these tears are large holes. These are large holes in the rotator cuff that we're able to repair back down and quite nicely. There's another large tear there, the befores and afters. And so there's an important rehabilitation consideration, and that is with the sling. You know, as I mentioned, the typical rehab has been in a sling for 6 to 8 weeks. There's been some research that showed that maybe we can go without a sling if we have a real stable repair. Well, using the biomechanics data that I just showed you, it is shown that it's safe to come out of a sling. And so the last 100 or so rotator cuff repairs that I've performed, 92% of them have had this progressive rehab protocol, which is decided at the time of surgery. If the tendon repair is good and the tissue is good, then I have patients come out of their sling as tolerated. And so the average time in the sling has been 2 to 2.5 weeks, which is a lot different than 2 months. And patients slowly but surely get their motion back. And it's been very, very encouraging in our early experience. A couple patients that have been nice enough to share with us how they've done. Here's a healthy 75-year-old with a large rotator cuff tear that was repaired through a scope. He wore a sling for 2 weeks, and he kind of weaned out of it the next week or so. And here he is at 8 weeks, raising his arm. And oftentimes, like I said previously, we would just be getting a patient out of the sling at 8 weeks. So he's doing very well, and he's continued to do very well. Here's a patient who had a very large tear. You see up at the top left, there's his repair on the bottom right. And then here he is at 8 weeks after a surgery, after a very large repair and a very good range of motion that's maintained itself now for about a year. And so in summary, rotator cuff problems, they're very common. They often can be managed non-operatively with physical therapy, activity modifications, etc. But if the rotator cuff tendon is torn and if symptoms persist in spite of physical therapy, activity modification and time, arthroscopic repair is a very successful procedure. We've been doing a lot of research on trying to make it even more successful and to improve the experience through our ongoing research and development, in particular the rehab process. Lastly, an example of a patient, there was before and afters, and here he is at 8 weeks, very pleased with his result. So thank you all for your time. That's some of my comments on the rotator cuff repair. And now we'll switch over to Dr. Loeffler.
Thanks, Pat. That was an excellent talk and lays the foundation for my talk, which is talking about tendon transfers for rotator cuff tears. So I'll tell you, when we can't really do a repair, we're doing a repair is not the best thing for the patient, that we have to kind of look at some different options here. So I'll show a couple of cases of cases where we use a tendon transfer and how it helped the patient. So younger gentleman for a big rotator cuff tear, 47-year-old. He owns his own landscaping company. He actually had a very large rotator cuff repair, and he's one that Pat was talking about that had a repair, but unfortunately it didn't heal or retore. His original injury was a motorcycle accident, but he's still having a lot of weakness and pain, and he's kind of been working through it. But he has a lot of difficulties with overhead activities, and he can't rotate his arm away from his body. His x-rays show that he's got no arthritis in the shoulder. And here's an MRI scan, which you can see those little screws that Dr. Connor was talking about that were placed in the bone, those anchors at the time of the repair. But the tendon, which is out here, is supposed to be attached to the bone out here. And you can see it's clearly retorn both on the top and the front of the shoulder as well. So that can be a challenging situation. This is another case, real active 45-year-old female. She also had a repair done about a year previously, but still has weakness with overhead and with rotating her arm. And she's very into CrossFit. In fact, she took 6th in the world in her age group a few years ago, and then the next year came back 5th in the world. She's also a CrossFit instructor, so being in the gym is like her livelihood as well as her passionate hobby that she has. And she had a rotator cuff tear, had a repair done. The MRI images again show a bunch of these suture anchors in place, tendon not attached to the bone. And just to show you, this is somebody who is extremely strong and fit, but that left shoulder is really limited by this rotator cuff tear. She can't rotate her arm and can't even lift a 10-pound weight overhead. So what do we do with large rotator cuff tears and massive rotator cuff tears, that are not amenable to a repair? So oftentimes you'll hear the term of irreparable rotator cuff tear. Well, there's a small subset of patients that we can kind of just clean up the shoulder. So that's with the scope that we can debride things and smooth down the bone, and that can help a subset of patients. Repair, as you heard about, is a good option when we can do it. Tendon transfer is really what I'm going to focus on. There's using grafts, something we call superior capsular reconstruction can have a role. Also, and then even a reverse total shoulder replacement can be an option for some patients that have, particularly if they have arthritis associated with an irreparable tear. So I'm going to focus on tendon transfers, but just wanted to mention that there's a large range of things that can be done for rotator cuff tears. And it really depends on a lot of patient factors. So things that we evaluate when we're discussing with a patient, how should we treat them? Depends on their age and hand dominance, what their occupation, hobbies are, and physical demands. Have they had any surgeries before? Do they smoke, which can affect the healing rates? And is the tear repairable? How likely is it to heal? And do they have any arthritis going on in the shoulder? And then, as Dr. Connor mentioned, there's a lot of variability in surgeon experience with different techniques. So doing things arthroscopically, doing transfers, doing reconstruction, or even replacement with these can play into how a patient is recommended for surgery. So first off, what is a tendon transfer? Well, a tendon is what connects your muscle to bone. And what we do is we move the attachment site from that tendon and a muscle that's working well to the site where the rotator cuff tear is. So can't put the rotator cuff there, we put the different tendon in that place. And I'm going to focus on one particular tendon transfer, although there are several that are available around the shoulder. But probably the most common one that we do is a lower trapezius transfer. So this is just a drawing of a patient lying down on their stomach. And you can see the LT, that's the lower trapezius muscle, and where it normally attaches is on the shoulder blade here. So we take that and we move it over to where the rotator cuff attaches to fill it in its place. And we are able to get there by lengthening it with a graft. So a couple studies on the matter showing anywhere from 90 to 97% of patients in these series, carefully selected patients who had significant improvements in their pain, function, and range of motion anywhere from 1 to 4 years out from the time of their surgery. And the nice thing about it is it doesn't burn any bridges, so they still could have the shoulder replacement in the future if their arthritis progresses or if they don't do well with the surgery. Now, the rehab on these is different than what you heard on the accelerated protocol that Dr. Khan is using on more straightforward repairs where we can do anatomic repair. With these, we're a little more cautious with the tendon transfer. Of course, we have the graft there as well. So they're really in a sling for about 6 weeks, and we do these similar to what we typically do with a massive rotator cuff repair. So you can move the elbow, wrist, and hand, but it's not a whole lot of shoulder motion in the first 6 weeks there. And then we start progressing from there, but it can take at least 6 months to recover from these. And sometimes patients are a little quicker, but sometimes it takes a bit longer. So just to put it a little bit into perspective, what my own personal algorithm is when you're talking about a massive rotator cuff tear, I mentioned sort of different treatment options that are there. And I think, again, it's a conversation with the patient, really individualizing the treatment for the patient. But somebody who's in their 70s, 80s, who's kind of lower demand, and they still can raise their arm up overhead, sometimes we can just smooth down the bone and clean up the shoulder, and that works well for them. If we've got a tear that's repairable and has a reasonable chance of healing, we're going to repair it. In cases where you have people that are kind of in their 40s to around 60 or so, if they have a large irreparable tear, I'll do the lower trapezius for the tears that are kind of on the top and the back of the shoulder. And then there's a latissimus transfer that can be performed, which is a different muscle in the shoulder that can be used when they have a tear that's more in the front of the shoulder. Some surgeons do a superior capsular reconstruction. So that's for people, again, without a repairable tear that have pain and have problems with overhead motion and function. And then usually in general, and these are all kind of vague indications in terms of there's a little bit of wiggle room with any of these, and when you're getting over 60, pain, arthritis, and lacking overhead function, that might be one that's best off with a reverse shoulder replacement. So going back to my first case there, this is a gentleman. He was back 4.5 months post-op, and he was running his landscaping business. He was very motivated to get better. His strength was functional and improving. He said his shoulder was about 85% of normal, even by 4.5 months post-op, and he was very happy with it. This just shows how he's now able to rotate his arm out to the side. He really couldn't rotate it before, and he can get his hand behind his head as well. So as you can see in the image there, he was very happy with that. And he continued to get better, and I saw him for some other conditions, but he was getting better even a year or so post-op. Here's getting back to our world-ranked CrossFit expert. This, again, was showing her pre-op with 10-pound weights and just not even really able to get the dumbbell into position to try to eke out one rep. And then 9 months after her lower trap transfer, you can see is pretty natural movement that she has there to get a heavier weight, 15 pounds, so 50% higher weight, and then she can just crank out reps here. And the webinar is actually not long enough to show how many reps she's able to do, so I'm going to keep moving along. But here's her at 3 months post-op. She can already raise her arm overhead. And then there's not many out there that can do 120 pounds overhead, let alone with a massive rotator cuff tear. So if that wasn't impressive enough, she was able to get back in the CrossFit Games about 18 months post-op. She can walk on her hands, which is absolutely incredible. And we were, really happy with her progress there. But she said, I'm not stopping there. She's very motivated to continue getting as much out of this as she could. And amazingly, she actually took second place in the world last year at the CrossFit Games. And so this is one where I should have that disclosure at the bottom that, these results are not to be expected by every patient. But it just goes to show that with careful selection, everything goes well with the surgery and rehab, that excellent result can be achieved, especially for patients who are on the younger side for rotator cuff disease and are heavily motivated. So in summary, these tendon transfers do have a role in managing these rotator cuff tears that really can't be repaired, or ones that have been repaired before, and the likelihood of it healing a second time is low. You can get better pain relief, range of motion, function, and strength. And as I mentioned, there's other tendon transfers that we do also for weakness from other muscle problems in the shoulder. So just want to say thank you again, and on behalf of the OC Shoulder and Elbow Center, thank you for listening and for entrusting us with your care.
Great, thank you, Brian. That was awesome. Just go to our so we're going to field a few questions. And maybe the two of us will both answer. And one of the questions here is how soon postoperatively do you begin therapy? I think it depends on the different surgeries that Brian and I were talking about. I'll just say, after a typical rotator cuff repair, most surgeons have their own specific way of doing it. The way I do it is the patient will have surgery. It's arthroscopic. They'll go home. Their arm's in a sling for several days. And then I typically don't start therapy right away. I let the dust settle for a week or 10 days. I think it's good for the soft tissues and maybe the inflammation after the surgery. Just use a lot of ice. And then when we see patients back and take out the stitches that are in those small little poke holes, then I typically will start physical therapy right around the 10 to 14 day mark.
Yeah, and I do the same. I agree. The literature hasn't really shown a benefit in starting a therapy in that first 10 days or so, and it really can be kind of torment to do that. You're really trying to let things settle down. So I usually will do the same for standard repair. When you get into a massive repair or one of these tendon transfers, then sometimes I'll start, if I think the person needs a little more guidance, I'll have them start the physical therapy after 10 to 14 days. But some people, I just tell them, come out of the sling, move your elbow, wrist, and hand, kind of keep the shoulder still. You can take it off to shower and dress. And then I'll start the formal therapy at about 6 weeks or so.
Here's another question. Should I have a partial rotator cuff repaired surgically? So that's a partial rotator cuff tear. So that's another way to state that is wear and tear. And so we see those partial tears on the MRI. And sometimes those can be just as painful, if not more painful, than the bigger tears. It's a little bit like a paper cut. The smaller ones sometimes can hurt the worse. We go through the same type of algorithm as far as non-operative treatment, try to get it better. There's 18 muscles that attach to the shoulder blade, so there's a lot of potential for compensation, getting all those muscles on the right page, help with inflammation, et cetera. But there are a subset of patients that continue to have pain after these partial rotator cuff tears. And in that setting, we can go in and get rid of the bone spur that's pinching on it that might be aggravating it, take care of the bursitis, make sure there's nothing else going on. And there's different ways to address those partial tears. They can be repaired if they're just hanging by a thread, meaning if they're almost always or almost completely torn, we would repair them as I showed there. Sometimes we can put a patch over them, which is essentially like a patch over your jeans, which can reinforce it, which has even a easier post-op rehab. And so there are different ways to address it, but yeah, sometimes partial rotator cuff tears need to have surgery.
Yeah, I would agree, and it really just depends on the patient, how long it's been going on, how much it's bothering them, what their goals are, what type of conservative or non-operative treatment they've had, whether we will discuss surgical treatment for a partial tear. All right, symptoms of a rotator cuff tear. Is surgery always necessary? Definitely not. A lot of these tears are wear and tear that occurs slowly over time. And as they do, a lot of times the shoulder can compensate for that. And a lot of times just doing exercises and living with it, it can be a great option. I think when you have an active person who has an injury and the tendon tears off the bone, that's one that we really we usually jump to trying to do a repair to get the shoulder back as normal as possible, as quickly as possible. But again, it kind of depends on how long it's been going on, how old is the patient, what's their activity level, what's the tear look like? Is it one that's likely to heal with a repair, or is it one that maybe just needs to go straight to a replacement even sometimes if we already have arthritis present? So really the devil's in the details, I would say.
Yeah. Interestingly, it's pretty common where we'll see patients that we can tell on their MRI, they've had a rotator cuff tear for a very long time, but we'll ask them, we'll say, well, how long has it been bothering you? They say, well, it just happened about 6 weeks ago when I fell up a few stairs and landed on my arm. And we can tell on the MRI that they've had a long-standing rotator cuff tear they didn't even know about, or a bit more of it, and then that's the part that was essentially the straw on the camel's back. And so we always try to be aware of that and try to treat these individually, but definitely surgery is not the first step in the vast majority of them. I'll let you answer this one. This is a tendon transfer question, Brian.
All right, how do age and activity level impact the decision to perform a tendon transfer? Some people may find that, not being able to rotate the arm out to the side isn't that big of a deal to them. So it really depends on, specifically what type of hobbies they have and what types of goals they have. If doing the tendon transfer is going to be able to get them to that level or not may kind of influence whether we would recommend it or not. I think a lot of times if you're seeing somebody who's up in their 60s, 70s, and higher even, while technically a tendon transfer is still possible, if they have some arthritis there and they have a lot of pain and they have a big rotator cuff tear, they may be better off if they've come to the point of having surgery that they just have a shoulder replacement instead. That could accomplish the goals that they're looking for. We have a little bit of reluctance in doing shoulder replacements and I'm talking specifically about reverse total shoulder replacements on younger people because as time goes on, those can wear out and problems can develop. So we try to preserve the native shoulder as long as we can. So especially when we're seeing younger people, we're trying to think of what can we do to prolong or prevent the need for a replacement.
Next question here. Is there one sport that you see rotator cuff tears from most? It seems like pickleball, we see injuries from everything these days. But I actually did a study quite a while ago and looked at MRIs and overhead athletes, and there was a higher incidence of rotator cuff tears in tennis players than baseball pitchers. But we know that all overhead activities put a lot of wear and tear and stress on the rotator cuff. I would probably say that tennis, people that play a lot of tennis have a bit higher incidence of rotator cuff problems. But you know what? It also can be in non-athletes, people who are laborers, people who use their arms over their head a lot. We see it in a lot of different forms. And genetics are a big part of rotator cuff pathology, And so even if you're a high-level athlete, sure, you can have a potential of wearing out your rotator cuff, but also even if you're not, based on what you do and how you do it and nature of time, sometimes it can catch up with us.
All right. Hi, I'm raising freshmen in college interested in medicine. What advice would you give to yourself? You could go back in time and start from the beginning. What's your favorite part about what you do and specialize in? Well, I think a career in medicine has got to be something that you love and passionate about, because it's a very long road. And in order to stay motivated, you have to kind of have the end goal in mind. But I mean, most of us went into medicine because we like the idea of helping other people. And I would say orthopedics is we're trying to get people back to doing the things that they love to do and the activities that they enjoy. And so I think if I could give myself some advice about going back into college and what I would do, just get exposure to what it's like to be a doc and to be a surgeon and what it takes to get there, and make sure that that's really something that you're comfortable with, and because it is a bit of a commitment with it being a long road. And the more exposure you can get, the more people you can see or along that road can give you an idea of whether it's something that's for you.
Yeah, well put. I think the favorite part of what I do is seeing patients at the end of the process, because patients come in and they're either hurt or hurting or having a hard time doing things, and then making an impact in their lives is really great. And it's they of course get a lot out of it, but we also get a lot out of it because that's what fuels our fire. So that's what I like. And I also like the fact in orthopedics that we take care of all people. We take care of young kids. We take care of high schoolers, college, professional athletes, but we take care of a lot of people into their 80s and even 90s. And so we have the full gamut of patients, which is really rewarding.
Yeah, couldn't agree more.
Next question: are there ongoing observations of success rate for PRP? Let me just make a little introduction. PRP stands for platelet-rich plasma, just as an intro, and it's essentially taking a vial of blood and spinning it down into the red blood cells, the white blood cells, and platelets. And the platelet layer is where our healing factors hang out. And so the concept is, if we can take off that platelet layer, we centrifuge it down, and we can inject that platelet layer into an area we try to get to heal. It's pretty cool because it's your own stuff. It's not from a lab. It's your own healing capacity concentrated. It has been shown to be helpful in some healing, some things in healing, and it's been shown not to be helpful in others. And so that's why it's important maybe to come by and talk to one of us or our partners at OrthoCarolina. We can talk to you about the things that help and the things that don't help. For instance, it's been shown to be most helpful probably with tendonitis around the elbow, medial and lateral epicondylitis. Tendonitis in the knee can be helpful. Some people feel like it's helpful with hamstring strains, but there are other things like ACL tears. It doesn't help. Meniscus tears. It's been shown not to be beneficial, other than maybe helping with a little inflammation, and rotator cuff tears. And so it depends on the specific pathology as far as it's applied. Anything else on PRP?
Well, it's one of the most studied interventions that there is. There have been so many different studies because, as Dr. Connor mentioned, there's a lot of appeal for doing it. You're using your own blood, you're spinning it down, you can get it in the office. It may prevent you from needing a surgery, or it may accelerate the healing process with a surgery. So yes, there are many ongoing observations, and I think we're just trying to find places where it does have a role, where it can help. So that's why there's been so many studies on it.
I will say one other point about the PRPs and stem cells. Those are all kind of under the same umbrella. And those examples of the rotator cuff repair that I showed earlier, that little pin, it's only 2 millimeters that we put in the bone. Well, a lot of people, when they repair rotator cuffs, they'll make little holes in the bone anyway, because essentially it aerates that area and it lets some of the stem cells come up in that area. It's called crimson duvet is what it's called. And so it allows the blood supply and the PRP and the stem cells to come in to try to help healing. And so that's part of the technology of our research and development to try to get as much of the healing factors there as possible.
What shoulder risks are there by regularly swimming laps crawl style regularly for years as a 70-year-old?
Can you show us that crawl style?
Crawl style, I think, is freestyle. So you're kind of doing this. Swimmers do run into problems with their shoulder, but you always have to weigh the risks and benefits. And the benefits of being active and doing things you love, all the health benefits from that. I tend to tell people, I want you to do the things you love. And so I think the benefits of doing exercise can exceed the potential risks of doing it because, as Dr. Connor even mentioned earlier, certain occupations where you would think would cause a lot of problems with the rotator cuff over time, or certain hobbies like swimming where you're constantly coming over, you would think that would wear it out, but a lot of people do tolerate it for a lifetime. So I wouldn't avoid it just prophylactically.
Yeah, a lot of it depends on what's going on underneath. We know that there are a lot of people that swim their whole life and never have a shoulder problem. A lot of people that run their whole life and never have knee problems. But if you have an underlying problem that can be exacerbated by those activities, that's where it's important to know whether or not you have them. All right. Are all doctors, the next question, are all doctors at OC using the new repair technique, or are some still using speed bridge, and who determines which will be used? I think that different doctors repair all things, whether it's rotator cuff or Achilles or patellar tendons or hip replacements or all the things that we do slightly differently. There's no right way to do things. Like I said, we're constantly trying to do things better. Ultimately, over time, if one technique proves to be better than another, then more people will transition over to that technique. So I would say that the answer to that question is very surgeon specific, and maybe dependent on the patient and the patient's tears and some of the specifics of that as well.
Yeah, I think, you want your surgeon to be comfortable and well-trained and experienced in the technique that they're doing. So sometimes people will come in and say they want a particular type of technique done. And, while like you said, there's a lot of different ways to do it, but ultimately you want the surgeon who's has a lot of experience with that particular technique. So yeah, there's many different ways to repair a rotator cuff. And so those can evolve over time, like Dr. Connor said, if research comes out or people get trained in a certain technique, then they may start adopting it. Role of primary care doc in pre and post-operative care. Primary care physicians can play a big role in preoperative management and postoperative. Also, a lot of patients who are active and having these types of problems, shoulder problems, may see their primary care sports doc initially, and so they may kind of go through all the different education and treatment options short of surgery initially, see if those will work. And then if they don't, then they may end up seeing an orthopedic surgeon. Of course, as orthopedic surgeons, a lot of what we see is we manage non-operatively as well. So we have the ability to kind of take people through the steps of non-operative treatment before suggesting a surgery or offering a surgery, and then guide them through the post-operative as well. I think the surgeon probably has more experience, especially with the post-operative care and knowing what's normal and what may be sort of outside the realm of normal, what a typical timetable is for recovery.
Yep.
Okay, well, thank you all once again for attending. And remember, a replay of this is going to be posted to the OrthoCarolina social platforms. If you have any other orthopedic questions, you have 24/7 access to an orthopedic specialist through the HURT app. So thanks again for having us, and thanks for a lot of great questions too. I hope everybody has a great day ahead.
Thank you all. Have a nice day.